Again, wanted to welcome everyone to the webinar today. I'm very excited for the panel we've pulled together for this conversation this afternoon. So you'll see here, we've got a great lineup for you, and we're going to dig into it in a second here for our conversation called A Double Dose of Physician Burnout, COVID, and EHR. It's presented today by an organization I'm a part of, Medix Technology, and we're joined by KLAS, Duke University, and UCHealth. So we're going to get through our panelists in just a second here. But I wanted to kick things off just to let you know that this webinar is sponsored by our team at Medix Technology. And remind you that, no matter where you're at in your epic journey, Medix Technology can help. So we're just so thrilled today to have this panel together to talk about hugely pressing issue in the industry that, we're happy to do our part to make an impact on. So, if you're interested in learning anything more about our organization, I encourage you to check out our website. It's medixteamtechnology.com, and you can learn more about everything we're able to do for you. But now I think it's time to get to our expert panel, what everyone has been waiting for, and to share some great information about our topic today. So to kick things off, I want to turn things over to the Chief Medical Informatics Officer here at Medix Technology, Dr. Brian Patty. Hey, Dr. Patty.
Hey, Andrew, thanks. I'm excited for the conversation today. We pulled together some real experts in the field of physician burnout, physician satisfaction. And as most of you are aware, burnout has significantly increased during this COVID era. And so each of our presenters today is going to talk about what they have been doing and seeing from a physician burnout standpoint, and what they have seen as far as changes to that landscape post-COVID, and some of the actions that they're taking to address those. And so I'm going to have each of our presenters introduce themselves, and then we'll get on with the presentation. Bob?
I'm Bob Cash. I'm the Vice President of Provider Relations at KLAS Research, and responsible for a lot of the work we do in what is called the ARCH Collaborative, which I will share a little bit about as we get into this. So thankful for the opportunity to share.
Great. Eric?
Hi, this is Eric Poon, calling in from Duke Health, where I serve as the Chief Health Information Officer. In that capacity, I oversee the clinical systems and analytics services at Duke.
Yeah, great to have you on board, Eric. CT?
Yep, I'm CT Lin. I'm Chief Medical Information Officer for UCHealth in Colorado.
Great to have you on the webinar today, CT. Well, we're going to start off, Bob mentioned the ARCH Collaborative. I think that the work that the ARCH Collaborative has done in the last several years has been really groundbreaking in helping organizations understand where they're at from a satisfaction standpoint and from a burnout standpoint. And so Bob's going to talk a little bit about the ARCH Collaborative and some of their findings, and give us some recommendations as to how we can use those findings to help our providers in this era. Bob?
Thanks, Brian. I'm excited to share, and I think it might be helpful to just start with a little bit of an introduction to the collaborative. Let's just talk a little about who we are. We started about 3 years ago with this effort and working with provider organizations to evaluate the experience of clinical end users with their electronic health record. And since that time, we've had over 275 organizations measure and over 190,000 clinical responses. Some of these have been international. We've had 33 organizations outside the U.S. measure from 9 different countries besides the United States. So it's been fun to see and learn across a wide array of organizations. We ask a standard question set, which obviously allows us to be able to benchmark and learn and improve together. So we call it a collaborative because our intent is to take those that have figured it out and learn from them and then share that with others. One of the key questions we ask is on the next slide. It's around, do you agree that your electronic health record enables quality care, and people can respond. And obviously, there's a wide array of responses that you can see on here. This is probably the most dense bar graph you've ever seen. So each of these lines represents a different organization, and you can see that the range is from, you know, nearly 100% that say that in their organization to less than 10%. So a lot of variety in response, which caused us to ask questions, you know, why? What is it that makes this big difference? The next slide shows these lines from top to bottom show different electronic health records. So the very same electronic health record, regardless. So there's 6 or 7 different EHR vendors on here. Regardless of which one you have chosen, you can have a variety of experiences. So you can see that you know, vendor X has organizations who love their experience, end users, and they have people who are having a not very good experience. So why is that? Where does that variation come from? It could come from several areas. The most likely culprits, right, that we would think of would be from the vendor themselves, the product. It could come from our organization. Maybe we didn't implement well. Maybe we haven't done enough to help our end users, or we don't have the latest instance. I know Brian's going to talk about that. So those issues can occur. It could be the end user themselves. They haven't, you know, taken advantage of what's been offered. They aren't maximizing their use. In reality, what we have found is that they are all three involved in the successful end user experience, but the larger opportunity comes from helping our end users to have a better understanding and better use of the tool. So since we're not just talking about the electronic health record today, but we're also talking about burnout, what have we learned through the collaborative about where, why, and to what degree burnout is occurring? I think that's a good level set as we kind of go through this. It's not news to anybody that there's been a lot of talk about the electronic health record and burnout. You know, here's just a sampling of the kinds of conversations that have happened in the literature and in the public press about the electronic health record and burnout. But what are we learning from the collaborative? This chart just shows self-reported burnout from physicians across a large number of organizations. And again, you can see here they range from less than 10% reporting burnout to nearly 50% reporting burnout in the various organizations that we've measured. And there's a lot of different things that can contribute to that. Frankly, the type of organization actually is a little bit of an indicator. You can see here that larger organizations and the complexities associated with those organizations seem to have higher levels of burnout. It may suggest that we need to find ways to address those complexities, which I realize, having worked for healthcare organizations a lot of my career, it is easier to rally around a cause at a smaller organization than a larger organization in general. It also matters where you are in your career. So I don't know if this is what I would have thought, but it's intuitive now that I think about it a little bit. Those at the beginning or the end of their career are less susceptible to burnout, or at least don't state that they're closer to burnout. And if you think about it a little bit, perhaps those that are early in their career are excited, they're actually more comfortable with technology, all of those kinds of things that we would expect. I probably was a little more surprised about those later in the career, but maybe they are either resolved or looking to the horizon. So we'll hope they're resolved. So what are some of the contributors and correlations to burnout? And we realize that correlation is not causation. And so please don't take any of these data as, oh, they're saying that because of this, people are burning out. These are just correlations. They certainly are likely contributors. But first is just what are the areas that clinicians have described as areas that are causing their burnout. And you'll note here that specific reference to the EHR as a contributor ranks number 3, but really the top 3 contributors could include the EHR as at least part of the problem. And that said, really, burnout is complex, and it has a lot of factors that contribute, several of which have little or nothing to do with the EHR. So if you're really going to tackle burnout, EHR is a component. There are things we can do there, and we're going to talk about that today, and I'm going to share a few things, but you really would want to be looking at other things, you know, the layout of their office. I mean, there's just a whole lot of things that can contribute, workload being way up there. So we didn't initially ask any questions about turnover in our surveys. So more recently, over the last year or so, we have asked physicians to kind of predict whether or not they anticipate leaving an organization in the next couple of years. And you can see here that burnout contributes significantly to those thoughts of leaving the organization or even the profession. And so not surprisingly, the more discouraged the clinician, the more likely to consider leaving. We also looked at burnout as it relates to the electronic health record satisfaction, and you can see here that that same correlation exists. If I'm highly dissatisfied with the electronic health record, I'm more likely to suggest that I'm burned out. And obviously, if I'm more satisfied, then I'm less burned out. Again, correlation, not necessarily causation. And then the impact of or attrition levels that are tied to the electronic health record satisfaction. Again, similar correlation, not the dramatic differences in numbers, but you can see that dissatisfaction with the EHR correlates closely with speculation on leaving the organization. Since we're talking also about COVID today, again, even less data here from KLAS because it's so new, but we have had the opportunity with a few organizations to measure the impact of COVID on burnout. And this first one really has nothing to do with that, but I thought it was an interesting FYI on the benefits of technology during COVID. You can see from this chart, and not surprisingly, telemedicine and telework are the highest on the list, but organizations haven't, at least in these few organizations that we have measured, haven't seen as much benefit yet from analytics and remote patient monitoring. So areas for continued opportunity. Perhaps what's really interesting is the increase in self-reported burnout from pre-pandemic to during the pandemic. The number of people reporting definitely burning out or symptoms won't go away or completely burned out increased pretty dramatically. And another view of that, looking at that from a percentage standpoint, we have seen, at least this would suggest that the perception of burnout during the pandemic versus before more than doubled. Now, it's really important to note that this is perception. And the actual burnout rates from this limited sample are very similar to the overall rates across the collaborative, 150 plus organizations prior to the pandemic. You remember the slide we showed earlier that ranged from 10 to 50% of people in an organization reporting burnout. The average across that is in the mid-20s. So, but if we ask people their perception of where they were before the pandemic and where they are now, that's what you're seeing here, more than a doubling. So it's interesting to know all of this. It's interesting to see these challenges, but what can and should we do about EHR-related burnout? And it won't surprise you that the things that create successful EHR users are the same with or without a pandemic, and regardless of the levels of burnout. I'm sure there are additional things we could do and different things we can do, but we certainly shouldn't stop doing the things that made sense before. And collaborative learnings would suggest that there are three areas that we should focus on. And those include the end user's experience or their training, their mastery of the electronic health record, their involvement in decisions around the electronic health record and quick response to their concerns. And finally, their personalization or their ability to kind of get out of the EHR what's intended, but in a way that works for them. So those three pillars certainly impact burnout and they impact retention. And so I just want to end with three quick slides that kind of show that. The first one here shows that initial training, those that are more satisfied with their initial training are less likely to suggest they're going to leave the organization. Similarly, as it relates to ongoing training, if they feel like they have had a great experience with ongoing training, they are less likely to suggest they're going to leave the organization. And finally, as it relates to governance and culture, if they have had a good experience with IT, they have a trusting relationship between them and IT, we're going to retain our best and brightest. So a lot of very interesting information coming out from more recent information that we've begun to gather in the collaborative related to burnout, turnover, and the COVID experience. So I'm excited to learn with Brian, Eric, and CT about their efforts to address these extremely important challenges.
Thanks, Bob. And you know, one of the beauties of the Arch Collaborative is that ability for an organization to benchmark themselves against other organizations. If you're just measuring within your organization, you get some information, but you don't know how you're related to other organizations. And so I think that that's been the beauty of the collaborative, is that standardized question set across organizations and the ability for you to then dig into where am I significantly different than another organization. And also the Arch Collaborative does an excellent job of recommending and identifying opportunities for improvement for organizations. And so it's just, I think it's been a game changer for our industry, and I encourage people to explore the Arch Collaborative if you haven't already. So I built this slide partly off of what we've learned from the Arch Collaborative, and partly what I've learned from you know, my 20 plus years of doing this, and really looking at, you know, how do you build a physician satisfaction program. And really the foundation is that your core EHR, how well you've deployed that. I'm familiar with the Epic world, and Epic does a great job of telling you kind of here's the things that you should be paying attention to with their Gold Stars program. I think it's a great place to start for an organization, is to really look at those and say, what is it I need to be doing to improve my instance of the EHR? Other EHR vendors do the same. And then making sure that you're deploying associated technologies or supporting technologies like voice to text, virtual scribes, using voice for navigation, things like that, because that just improves ease of use for your end users. And then single sign-on. I'm a big fan of single sign-on. I've used Imprivata, but there's plenty of single sign-on options out there, and making sure you're utilizing that single sign-on functionality both in-house and remotely. Bob mentioned the three pillars of training, governance, and personalization. You know, a good training program, you're making sure you're onboarding your physicians well. You make sure you have an ongoing education. I know that there's been a lot of recommendations that physicians should receive 2 to 4 hours of education on their EHR annually. If you don't have a robust training program, it's hard to deliver that. And offering real-time support. I'm a big believer that every call to the help desk that's made by a physician gets routed directly to your training team, and your training team is responding, and the ability to do either at the elbow or in the COVID area at the ear support. And so being able to do that. And then governance, really giving your end users a voice. And making sure that those voices are educated. I like to have everyone on my governance team having gone through either the Physician Builder program or the Power User program. Again, I'm familiar with Epic. There's other programs with other vendors, but making sure that those on your governance team are educated about what the EHR can do. And then again, governance really is a focus on workflow. Make sure that all of your key workflows at your organization are represented on your governance committee, whether that's you know, the hospitalist for inpatient, surgeons, the emergency department, ambulatory, and then all of your specialties, you know, peds, OB, cardiology, and on down. What are the specialties that are most important at your organization? Make sure that they're represented in your governance process. Personalization is key. Again, this gets back to your training team, because they're going to be doing a lot of this with your providers, but making sure that you sit down with each provider and they're taking advantage of the tools that are available in your EHR and personalizing those tools for their workflow. And then communication. Communication kind of broadly goes over all of these. If physicians and your end users aren't aware of the availability of training, aren't aware of the voice that they can have within governance and what's coming out of that governance committee and the changes that are occurring, and making sure that that your end users are feeling heard with your communication. Here's what we heard from you. Here's what we're doing to address that. Those are all important things in that communication program that kind of is overarching over those three pillars. So I want to turn to CT now. CT, I know that UCHealth is really cited often for the sprint program that you've developed and perfected. You know, a lot of organizations are building programs based on what you've done and the success that you've had. So tell us a little bit about your sprint program and how you've adjusted that program based on the post-COVID era.
Thanks, Brian. If we could go to the next slide. Things I was hoping to cover today would be about our sprint program and the optimization of the electronic health record to reduce burnout. And then during the pandemic, you know, what did we do with the sprint team? I'd like to cover that. And then did burnout increase during the pandemic? I think that's already been partly answered, but I'll give you some of our statistics. And then what has UCHealth Informatics done during the pandemic? So that's where we're going. Next slide. So number one, sprint team. Next slide. So this is our typical clinician user, and here's the monthly email newsletter from CT Lin with all those EHR optimizations, right? So CT Lin happens to be contributing to the burnout because I spam 6,000 physicians every month with our EHR optimization newsletter, and a significant fraction of our docs just put that into the spam folder and never look at it. We know that our open rate for our newsletter runs about 17 to 27%. So 3/4 or more of our clinicians are not seeing the optimizations if we do this as a broad base, broad brush stroke. So what we did develop in contrast to that is an intensive 2-week sprint. The idea that we would take 11 sprint team members, a physician, a nurse, a project manager, 3 or 4 analysts, and 4 or 5 EPIC trainers, and we would descend into the practice and live there for 2 weeks. Practice sized up as much as 30 physicians and their associated staff. And the way this works in our current format is that 90 days prior to the sprint, we start doing pre-sprint meetings. It's an hour at 90 days, 60 days, and 30 days. We do a survey, and then the kickoff on day 1 is a 2-hour training for all physicians, because within about 2 hours, we can teach you 6 personalizations that, surprise, people who have worked in our system for up to 10 years have never done, right? In the beginning, when we gave them an 8-hour training, we're like, make sure you do all this personalization on day 1, and they get there and they're overwhelmed with everything, including patient care, and whatever it takes for you to survive through that day, you go, well, that's all I want to know about EPIC or the EHR, and don't bother me, right? Because I can make my way through, and you never go back and go, I wonder what else I could figure out, right? The whole division between digital natives and digital immigrants. We have a substantial fraction of digital immigrants who are like, well, if I touch anything that I'm not supposed to be touching, I'm going to break something. So I'll just stick with what I know and not go back and learn more. So here we are doing not only kickoff, but then one-on-one training. We are dedicated to doing 7 hours of one-on-one with every physician in that practice. And then we also do daily huddles with the clinic leadership so that we constantly adjust what the major priority is for that clinic. If we come in thinking that discharge prescriptions are the main thing to think about, but then we find out that no, it's actually refill process that's most broken in this clinic, we'll pivot because we're meeting every day trying to figure out what's most important to work on today. And then over 14 days, we conclude that, and the wrap up on day 14, we end up having an all clinic meeting and saying, these are the things we built for you. Not only do we do training, but we have done optimization that's specialty specific. And we say, this is what we've built. Make sure that you use it today while we're still here, and then have you used to the new tools. And then we survey on our way out. And we've done this now with nearly 100, actually several hundred practices, and the details down there at the bottom. Next slide, please. Here's an action shot of what we're doing, right? And click forward one. And so you have break fix and improvement tickets tracked on the wall over there. That's now all electronic, but it was nice to have 3M Post-its that were very visual. We have sprint leaders huddling every day. We have providers and staffers tracking who's come in for training. We have one-on-one training on site, often in the provider's exam room. and then analysts fixing and building new tools. Next slide. So we used Net Promoter Score, something similar to what Bob has developed, customized to the EHR. Net Promoter Score, if you haven't heard of it, is 0 to 10. How likely is it you would recommend blank, in this case, the EHR you use in your practice, to a friend or colleague? 9s and 10s are promoters, 0 to 6s are detractors, and then we come up with a single number. And then range goes from -100 to +100. We know that -100, everyone hates you. +100, you're golden. And plus 0 to 30 is pretty good, and +50 is excellent. Our physicians pre-sprint 10, so slightly positive, and then our staff are +24. And post-sprint, within a 2-week period, you go from 10 to 47. You go from 24 to 46. You go from, yeah, this is okay, to actually, I like this quite a bit. And the nice thing is the NPS for the sprint itself. How likely is it you would recommend sprint to others? If you next click, we hit 60s and 70s. This is the zone of where Apple lives. Apple lives at a +70 in the computer industry. So we like how that's going. Next slide. Let's move on to the next slide. Yeah, so we've published our experience. Not only had the Mayo Clinic proceedings, not only do we do the top outline, but please look to the supplement. The online supplement actually details in great detail how we set up our 14-day sprint. Next slide. So how did we use the sprint during the pandemic? 2 things. The sprint went virtual. We actually were prohibited from going into the practices that were still open. And so we ended up using Microsoft Teams and Zoom, doing one-on-ones remotely. Actually, because the surgeons weren't operating, we actually got better engagement from our surgeons and less distraction, which is interesting. And then since about September or so, we've gone into a hybrid model where our training is on site, because that actually does take place better in person. And then the analytics, the people doing the design, are offsite. So about 2/3 of our team are remote and 1/3 are on site. And then at the same time, our sprint team ended up helping our virtual practice team scale up our virtual visits. So you'll see here, the scale is that we were doing about 10 virtual visits, 30 virtual visits per day prior to March. And then if you click through, you'll see that we jumped from 20 per day to up to about 4,000 visits per day in a very short period of time. We trained 1,500 doctors in about 10 days. And then that number has gradually edged off as we've ramped up our in-person visits again, down to about 1,000 per day, but we're steady at about 1,000 per day now, which is still, orders of magnitude beyond where we were before. Next slide. So did burnout increase during the pandemic? I think the simple answer is yes. Next slide. It's no surprise, physicians and care providers value patients' lives over their own. We went into healthcare not because of a profit motive, it's because of helping others. It's a profession of selflessness. And burnout has gone from the mid-30s into the mid-50s, and particularly and surprisingly, our APPs, our advanced practice providers, are into the 60% range for burnout. And that's because we're throwing our bodies at the front line and saying, when patients need the care, we're there for them. And that's at the cost of our own wellness. And so we've actually set up an entire structure of a wellness working group. We call it WELDM in the Department of Medicine, but broadly we have a wellness initiative across the system. We're working on the tripartite model that Tate Chanefelt and others have developed. It's a culture of wellness where you're actually addressing all leaders to think about and support wellness, practice efficiency, which is our sprint program, and the component of personal resilience. And I'll caution those who are doing this work, and I'm sure most of you have figured this out, so if you start with personal resilience, people come and get very offended with, so you have a terrible EHR and you want me to meditate to make me better, right? Is that what you're saying? Because no, that's not it. So we're like, be very careful how you approach wellness, because you have to say this is a package deal. It's efficiency, it's governance, and it's your personal piece, because any one of those pieces missing, you don't get to where you want to go. And we have been gratified by receiving the AMA Joy in Medicine Award, for the Bronze Award for the infrastructure we've set up. Next slide. And then what did informatics do during the pandemic? Next slide. We published a paper. What else do we do in an academic center? Informatics accelerating health system adaptation during COVID-19. And we published 14 examples in the paper. The first one being, next slide, the COVID algorithm pathway. Oh, that's not showing exactly right. But we actually built a pathway that's partnered with our Agile MD innovation partner, where every day, because we're making decisions on who to test, who not to test, which test to order and that sort of thing. We built that into a pathway and changed it sometimes hourly during the pandemic so that clinicians knew, all right, I have another patient, click here, this is the current recommendation for testing, this is the current recommendation of treatment, this is when to escalate, and you don't have to make phone calls like, what's the current thing? It's right there on the pathway, and we keep that up to date. Those of you who watched MacGyver in the 1980s, right, you build everything out of duct tape, and so we built something out of duct tape. You know that ICU rooms are single occupancy, and during pandemic, we actually doubled occupancy, and yet the cabling in the wall is designed for one ICU monitor. Where does the second ICU monitor electronics go to? I don't know. And so we ended up putting a person in every doorway initially going, do you hear anything? Because we should run in there if you hear an alarm. What a horrible use of our resources. And so we ended up creating a Microsoft Teams permanently on channel on an iPad. You see that little inset of an iPad on a stick, rolled that into the room, face the camera on the iPad towards the second monitor. So you don't have to break the wall and start pulling cable. The Teams channel that's always on reports back to the aggregated iPad, and you see the iPad stood up right next to the actual video monitors. You have a virtual system for the second beds across all of the ICU. That was a very clever, a couple of nurses and a couple of physicians sat down and like, can't we just do this? And like same day, up and running. So very cool. Next slide. And then we've actually been working on using EHR data to predict hospitalization. That's been very difficult. But we've been trying to get, if the clinics are seeing an increase in cough, fever, shortness of breath, and if our testing results are starting to scale up, can we use that to say 4 to 8 days later, we think there's going to be a bump in hospitalizations? And we've been able to come up with some predictive algorithms to think about how we change staffing for our surge units. And that's been somewhat successful. Next slide. And that's it. So we built a sprint team. We did some different things with the sprint team. Burnout has increased, and we're officially addressing it because of the way we changed our internal governance. And we had some fun with our informatics team during the pandemic. Do we want to do that at the end, Brian? This piece? You're on mute.
Yeah, we can hold that to the end. A special treat at the end of the presentation. Yeah, thanks, CT. I mean, the work that you and your team have done has been, copied by many organizations. So it's great to see the adjustments you've made, so that other organizations can make those adjustments to their sprint program and their approach to the burnout. It's just, I love the MacGyver approach to solving a problem quickly. It's always fun to see. Eric, we all know that the EHR is only one piece, and CT, you talked about this a bit as well. It's only one piece to the overall factors that are affecting burnout. And I know that Duke has created a great global approach to burnout, and I'm sure you're going to tell us a little bit about that. And then, kind of what you have seen in your organization, what you've seen across the country as far as how organizations have adjusted in the pandemic era.
Well, great. Well, first of all, CT and Brian, thank you for deferring the special treat from CT until the end. If you didn't, it would make it impossible for me to follow CT's act. So thank you for sparing me the blushes. So this is Eric Poon, glad to join you and share with you some of the things that we have learned at Duke. And I would say in that capacity, we have stood on the shoulders of giants. Like Bob and CT and Brian, I think I would call out before I begin that we are also part of the ARCH Collaborative, and one of the things that we are very excited about is that not only are we going to be getting our scores for our physicians and providers, we are going to actually get a read from our nurses and our allied professionals. So that's going to be an important part of our overall wellness program. And then, and thinking about your pyramid, your model, Brian, of how you build a physician satisfaction program. I think through our previous exchanges and on a professional front, we have copied many aspects of what you and CT have done at your organizations. But I think what I want to do today is to maybe point out a couple things that we have done at Duke that may be a little bit unique, and then share some of the lessons that we have learned in COVID that may inform what we collectively do as a community moving forward. And then a different perspective I want to bring to the discussion is that I've had the fortune of being a guest editor-in-chief for the Journal of the American Medical Informatics Association, special focus issue on clinician burnout, alongside with Kai Chang and Trent Rosenblum. And we have been preparing that issue that's coming out in April of next year, and I want to share with you some general impressions of what we are learning on this important topic around the country. So next slide. So many of you will recognize this as the face of Judy Faulkner at Epic. So if you think about the slide that Bob showed us early on about all the headlines that were popping up starting at around 2018 about the role of EHR in causing physician burnout, you might imagine that there are folks in the informatics community and within the clinical community that says, blame the EHR, burn that witch. And that's why I picked Judy being dressed as a witch at this for this slide. But next click. But at Duke, we also have you use the devil as our mascot for our sports team. So we at Duke, I think, may have a more balanced approach when it comes to thinking about provider burnout. Next click. And then the short of it is that while there is a relationship between EHR and burnout, I think it's actually important to acknowledge that it is a multifactorial problem. And as I reflect on my journey at Duke over the last 6 years, every time the issue of burnout is being discussed in general, I poke my head towards one of the clinical leaders in the room and think, okay, what can I do as the person who's the lightning rod for EHR to help mitigate it? And actually, to my colleagues' credit, all of them, without much prompting, told me that, well, the EHR is only one of many different things. There are lots of changes in medicine, and perhaps more in the academic world than the non-academic one. There are evolving expectations for what clinicians need to do, and particularly in the academic world, when you are trying to be great at clinical care, at teaching and research, it is hard to balance all of it. But because burnout has such a wide set of causes, the solution is not going to be simple. There is not going to be a silver bullet. And at Duke, we have very much learned from what Ted Schenefeld has proposed with the tripartite program, and we have really promoted wellness under the framework of how do we help providers find joy in what they do. And it is not just celebrating our successes as clinicians, although that's important. We have done a lot in the last few years in empowering our clinicians, not just around the use of technology in medicine, but really around how do they take charge of redesigning the work, redesigning the local environment. So we've rolled out as part of the work in the last couple of years, organizationally, a lean driven program where we have organizational huddles and everybody talks about what's going well and what are some of the challenges and what they're going to be working on today to address them throughout the whole practice and throughout the inpatient units. And then there's also been some really important work in training teams how to react better to difficult situations and how to improve patient satisfaction. So I think those are important elements of our overall wellness program. Yes, we do focus on wellness. I remember 2 years ago going to the patient safety conference at Duke, and I thought that I was transported to a new age a campsite where everybody was talking about meditating and gratitude, and those are important elements of doing wellness. And then communication, I have to imagine that communication is hard everywhere, and it's particularly hard to do because it's large and complex. And trying to make sure that folks know what's going on. I used to have a mentor that told me that in the absence of information, people make up expletive. And I think we have invested a lot of time. And so in many ways, the EHR and our efforts to democratize data has been supportive tactics in the big picture. So, and maybe this is obvious to the audience, but I think since we have come from this into this conference as a Medix-sponsored conference, I wanted to put this in the larger context. Next slide. So some of the things that we have done, I thought about, like that's a little special at Duke. Well, certainly our chapel is a little special for Duke, but on the burnout front, I think we've been an early adopter of putting additional support staff to good use to support our physician use of technology. We call them the concierge team. Actually, we have grown that team over time, and they really provide a lot at the elbow, and of course during COVID at the year support. And they partner closely with my medical informatics physician provider champion team to really think about not just how to use the EHR in a more efficient way, but really to think through some of the workflow challenges alongside with the clinic support staff. And then we make it very clear and very transparent what we are going to be working on through our governance process so that we can actually devote the right amount of resources to solve any problem of the day, be it meaningful use a few years ago to now information blocking more recently. And then I do want to emphasize that we actually have invested a lot in building partnerships with our operational leaders. I think without the buy-in, I think that any investment in IT or supported resources will have a diminished impact. I think a lot of times you do need to get clinicians to invest the time and to really pay attention to some of the things that are being brought to the table to improve how they do things. So, and I think I can't say enough about how having the right medical director and the right VP to support these initiatives really amplify whatever resource investments that we make in improving EHR-related burnout. Some of the things we have done, I call them tongue-in-cheek technology life hacks. I think one of the other speakers talked about the single sign-on solution. We've actually gone one step further beyond single sign-on to making sure that this single sign-on is fast because most of you know Epic works through Citrix, and Citrix does take a long time to get started. And so trying to make sure that the tap and go login is associated with immediate access to the EHR so that there's not that 30 seconds wasted has been an important effort that I think I can point to that returns like easily 5 to 10 minutes back to each clinician every single day. I think there was also some mention about remote scribing. I think we've had good success with remote scribing. Of course, that is not cheap. What we have successfully piloted is some new technology that basically is technology-assisted remote scribing, where from the perspective of the clinician, it is indistinguishable from remote scribing in that the clinician gets a note back in the EHR. But what is exciting about the technology is that on the back end, there is some technology that assists in formulating the note, and so that the actual human remote scribe can be more efficient. And what's been encouraging is that the price point for the ambient voice assisted remote scribing is making it a lot more attractive than scribing alone. And then other things that we have focused on is to make sure that clinicians have the ability to make use of the data that they and their colleagues spend time putting into the system. So we have, alongside with our provider organization, stood up a team that provides data to allow faculty members to answer questions that they haven't been able to get support answering, to drive some QI and research efforts. And that's been hugely popular. And of course, with Epic beefing up the self-service tools, I think we now are democratizing our data and making it part of the culture of practicing medicine. So just the other day, for example, our system-wide CMO was conjecturing whether there has been a change in demographics in patients who get COVID versus those who get COVID and then subsequently get admitted. And we were able to quickly show him that with Slicer Dicer, you can answer that question within 5 to 10 minutes. So I think this is part of our culture change in using data. And then maybe as those of us who think about post-go live optimization, that could be part of what you do. Next slide. So some of the lessons learned during COVID, I think it's been a pleasure to watch how a complex organization, when it actually turns its focus onto one single enemy, how amazing things can be done. And again, I want to emphasize how communication and transparency during a time of rapid changes can be an important antidote to confusion and burnout. Yes, did COVID lead to burnout at Duke? I'm sure it did, but I think we did a lot in being responsive and transparent. I think having a governance process that was basically redesigned just for the purpose of COVID so that we can quickly respond to emerging needs like iPads for patients, iPad on a stick in the ICU, and to actually stand up these new workflows to support new testing. We even actually opened up a hospital wing that actually was not ready early to house COVID patients. That was an important lever that we pulled in order to support all the transformations that are needed. And then we showed that it is possible to deploy technology quickly. Like many others, we deploy telehealth quickly. We also deploy other technologies like Epic Secure Chat very quickly just to make life easier. So we did not waste this crisis. We actually took advantage of the strengthened communication channels to get things out quickly. Next slide. So looking at the national perspective, I won't steal the thunder of JAMIA, but we are putting out an issue in the spring of next year focusing on the role of health IT and clinician burnout. So without divulging too much about what we are going to be saying in the special issue, I think some general observations that I could infer from some of the submissions and some of what's being discussed around the field is that I think there is a maturation in thinking. I think rather than blaming the EHR vendors, I think the EHR vendors are taking a much more proactive role in redesigning the user interfaces, thinking about workflows. So I think that is going to lead to some benefit down the road. And as has been alluded to by the other speakers, it's not so much about turning on specific features in Epic. Is really the field is migrating thoughts, thinking about the workflow. How do you help everybody practice at the top of the license so that you can actually improve satisfaction? I think one observation I would make in that the field is moving more towards a quantitative approach and using access logs, which are becoming more available in the large EMRs, to help them focus their energies in improving workflows and finding providers who might be struggling silently. And then I do think the EHRs are coming up with new documentation paradigms. For example, the problem-based charting has been worked on, and I think there continues to be successes that we can look to help people think about how to take better care of patients and have the note support that rather than having the documentation process be a drag. But I would say that there is really still no silver bullet, and there's still a lot of work that needs to be done to think about new approaches and new ways to disrupt how we deliver IT services to get at this multifactorial problem of clinician burnout. So that's what I have. So I'll turn it back to Brian.
Great, thanks, Eric. That was it's so amazing to see the comprehensive approach that Duke has taken. I will remind people we are using the Q&A function. If you scroll down to the bottom of your screen, you can click on Q&A and ask some questions. While you're finding that button, one of the things that I've always found helps with me with a burnout and relaxation is a little bit of music. And so CT, as many of you know who have seen CT speak before, he does write and present at the end of, write songs and presents those at the end of a lot of his presentations, and he's done something for us here today. So without further ado, CT is song of the day, if you will.
We wore masks and shields. How would we cope? But now with telehealth, I see your face shine with hope, and I think to myself, what a wonderful world. Here's a video screen. Screw you, COVID-19. There's no need for patients to travel to be seen. And I think to myself, what a wonderful world. The colors of the rainbow, so pretty on the screen, also indicate healing on the joints of patients seen. I see friends waving hands, saying, how do you do? They're really saying, IT, I love you. I see patients on screen, and we wave hello. Their pain is well controlled. I watch them get up and go, and I think to myself, what a wonderful world. Yes, I think to myself, what a wonderful world.
Oh, thanks, CT. It's always entertaining and always fun to see you sing. So one of the questions I wanted to ask is, what other innovations have you seen, specifically CT and Eric, but also Bob, that other organizations have done that have impressed you in responding to COVID and helping our frontline workers reduce their stress levels? I'll just open that up. One of the, while you're thinking about that, the other question I've seen come up a couple of times was, will we be posting the slides? And Andy, I don't know if you can post where we're going to house the presentation. We are recording this presentation, so we'll be housing it on our website. But Andy, if you can put that up, I believe it'll be at www.medixteamtechnology.com. But I do want people to have availability to the presentations, because it's just been some excellent content that's been shared with us here today. So thoughts on that that question?
I may not be.
I have a tongue-in-cheek answer, which is somewhat inspired by the video that we just saw. Zoom has given us abilities to actually do things online, and so one of the things that our organization has done is to organize some of the virtual events that's unrelated to work online. Interest groups such as cooking, people interested in fitness, people interested in music. There's certainly been talent shows, open mic sessions. Just because I think the interactions between providers or IT staff has been diminished because of the social distancing. So having the ability to get together and celebrate life in different ways has been certainly interesting.
I would just say KLAS talked to a whole lot of organizations fairly quickly after the pandemic occurred about what they were doing to respond. And I was amazed in my personal interviews and in the reporting that we did that with the creativity, frankly, that it's maybe it's the baling wire and bubble gum that Dr. Lin was talking about, but just amazing ways that you all have brought together a way for clinicians to continue to practice, patients to continue to get care in the midst of this crazy time. And a lot of it was around telehealth. But one thing I thought about, we talk sometimes about Kaiser Permanente Northwest has a pyramid of change that they use, and they use it for governance, basically to help decide when to make decisions. And we meaning you, the industry, moved to more quickly making decisions than we did before. And maybe there's something we can learn from that as it relates to governance, and keep some of those learnings that we found that allowed us to kind of do things more quickly. Mm-hmm. That's helped us survive and even thrive, I think, a little bit in this pandemic.
Yeah, one of the things that I've heard from other organizations, and that's great, Bob, it's just like the things that Arch Collaborative has done for our industry has been phenomenal, and you know, I applaud you for what you've done and what you continue to do. One of the other things, and getting back to Eric's comment about Zoom, one of the things I've been hearing from a lot of organizations is the loss of collegiality, you know, the ability to congregate and to just chat with your fellow providers has been really lost. And so it's increased the experience, if you will, of isolation. And so the ability, I would encourage organizations to use Zoom or whatever technology your organization is using to gather people together and have social events for your providers to chat and vent, if you will, and hear how they're all coping, and being able to congregate virtually because the physicians aren't, and all of your end users aren't able to congregate well in real time these days, and without risk. And so encouraging organizations to utilize some of these technologies that they've rolled out to bring people together, have group chat sessions, group video sessions, you know, group happy hour, if you will, and just open up ways for people to congregate virtually, since we cannot oftentimes congregate in person. Other thoughts?
I'll just make a brief comment that we know that what's protective in the burnout literature is the existence of a mentor or mentee relationship. So for those on the call who are not in favor of large Zoom gatherings and you know, gregariousness, even one-on-one meetings with a meaningful relationship can be incredibly powerful. And it's remarkable that both being on the mentor side or the mentee side of that relationship, both are protective. So it's something to think about during this pandemic, is reaching out to folks who you may have lost touch with and reestablishing.
It's so important because again, that's one of the things I've heard time and time again, is that loss of that sense of connectiveness, and we need to regain that in any way that we can, whether I agree one-on-one or small groups or large groups, however we can facilitate that at our home organizations, the better off we're going to get through all of this. So Andy, I don't know if you can post where we're going to post the recording so our attendees can share that with their organizations if they want, because I've heard that that's been the #1 comment and question is where can we find this?
Sure, we'll be following up after the presentation for the exact spot, but you can be sure that it'll be available on our website, medixteamtechnology.com, so people can access this fantastic content after the webinar today.
Okay, so everybody that's registered will receive a link to the presentation?
Yes, that's correct.
Perfect, perfect. Well, we're past the hour. I want to thank everyone for participating. This has been a great wealth of knowledge sharing. Bob, Eric, CT, thank you very, very much. And I'm sure that those who have attended have gained some significant knowledge on how they can improve back at their own organization. So thanks.